little because I have a couple more, quite a few others I want to show you guys. Any thoughts? What does it look like?
Is this a Dacron graph?
Yeah, it's a pantaloon Dacron prosthetic aortic graft. Use it for aneurysms, where the abdominal aorta down to the common iliacs are dilated in imminent risk of rupture. So we slice the aneurysm open and we place this on the inside. So putting these pans inside those pans which have gotten too big. So this will connect up to the aorta here. This will connect down to the iliacs. So it's a bifurcation aortic aorto-iliac graft. It's a Dacron graft. This one is a straight one where the aneurysm doesn't go beyond the aortic bifurcation. So this is just for aortic replacement. But this one is when it involves the iliac vessels and below. Spot diagnosis, anybody? Anybody? Nope. What are we looking at here? No takers? Come on, guys.
It's an anterior neck mass.
Yeah, we're looking at an anterior neck mass. That's right. What is it likely to be?
It's likely to be a thyroid mass.
It's likely to be a thyroid mass. What clinically would confirm that it's a thyroid mass? What would you ask the patient to do clinically?
I would ask them to swallow and also to protrude the tongue.
Okay, so you ask them to swallow. So they swallow and it moves up with swallowing. What is it likely to be?
If it moves up with swallowing, it's a thyroid mass.
Or
it could be a thyroglossal ductus.
That's right. When they protrude the tongue.
When they protrude the tongue, if it moves, then it's a thyroglossal ductus, but if it's a thyroid mass, it would not move with protrusion of the tongue.
That's right. So thyroid masses move with swallowing, but not with protrusion of the tongue. And that's what this patient has, a thyroid swelling. So clinically, this patient has an enlarged thyroid swelling. What's the next step? What do we do next? What are the two things we do? Let me help you guys out.
Okay, so past history and examination, you would want to investigate with thyroid function tests, and you would also want to do an ultrasound.
That's right. Thyroid function test and ultrasound are the two critical tests for these patients. If you were to pick just one thyroid function test, which one would you pick?
I would choose TSH.
You would do a TSH, that's right. And what information do you want from the thyroid ultrasound? Basic information.
Okay, so you want to see if it's solid or cystic.
Solid or cystic.
You want to see if it's well circumscribed or irregular. You want to look for any calcifications or increased vascularity to the thyroid gland.
And more basic than that? First things first.
Size.
Well, solid or cystic, diffuse or nodular.
Diffuse
is it a diffuse swelling or is it a nodular swelling? If it's a diffuse swelling, it's not a surgical problem. We send them to the endocrinologist. If it's nodules, it's our problem. And if it's nodules, we want to know whether it's a single nodule or multiple nodules in both lobes. That's the basic workup for these patients. Clinically, through the tongue, moves on swallowing. Thyroid function test, specifically your TSH, ultrasound looking for diffuse or nodular swelling. And then with respect to nodular, solid or cystic, one nodule, multiple nodules, unilobar or bilobar. What are your indications for surgery, Tanya?
Okay, so
indications for surgery for thyroid swelling.
you would want to perform surgery if you've confirmed that this patient has a thyroid carcinoma.
What clinically would be in keeping with a thyroid carcinoma? What would make you suspect it was a carcinoma?
If they have symptoms regarding compression, so they have hoarseness, there's also rapid growth of the thyroid as well, and also if they have constitutional symptoms.
Well, constitutional symptoms aren't really a feature of thyroid malignancies. They do so well. They don't impact on lifespan and so forth in the vast majority of cases. So if you wanted to get a cancer, pick a thyroid cancer. It's very effective the treatment. But rapid growth could suggest it, yeah. What other feature you said?
Hoarseness.
Hoarseness. Hoarseness is a critical feature. What would hoarseness tell you?
That there's compression of the recurrent laryngeal nerve.
Not compression, but invasion.
Involvement.
That's
Yeah,
right. It is in invasion. So hoarseness, rapid growth, and clinically you may feel lymph nodes. Those are the clinical things which may make you strongly suspect it's malignancy. So that's one indication, suspicion of cancer. What are the other two indications? What's our indication? Have I lost? What's her indication?
I'm back.
No, you're back. Oh, you're okay.
Sorry. In her case, it could be due to cosmesis as well.
Cosmesis, yeah, that's why I should want it out. Cosmesis, suspicious for cancer. And what's the other indication? Suspicion for cancer. And what's the other indication? I think you mentioned it somewhere along the line.
The compressive symptoms.
Compressive symptoms, either compressing the airway or the digestive tract. Those are your three main indications for these patients for surgery: compression, cosmesis, suspicion of cancer. The vast majority of them have surgery for cosmesis. Complications related to surgery?
Okay, so these patients can get damage to the recurrent laryngeal nerve.
Nerve injury. Recurrent laryngeal nerve. Any other nerve? Recurrent laryngeal nerve. Are there any other exposed nerves when you operate on them?
Not that I could recall right now.
The external branch of the superior laryngeal nerve, which supplies the cricothyroid muscle. So this line from the last. Intrinsic muscles are the larynx are supplied by the recurrent laryngeal nerve, with the exception of the cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve. Oh, that's all. I still remember that. They may damage the recurrent nerve, they may damage the external branch of the superior, it may even damage the vagus nerve itself. What else may be injured?
You can have, well, hematoma formation.
Blood vessel injury, that's right.
You could also have trachomalacia.
You get tracheal injury, okay, esophageal injury. What else may be potentially impacted on operation on the thyroid, particularly when you're operating on the both sides?
The parathyroid?
Yeah, you may end up with parathyroid injury, either removal or just from the handling you get some degree of ischemia, which may impact on your calcium levels. Anyway, can't go through all the details of each topic. All right, but I just wanted to, okay. Tell me when you guys are tired, how long have we gone? We've gone an hour yet? Backside, almost 6 o'clock. Come, all right. Who can tell me what sort of an image, what image this is? Straightforward. Can't get easier than that. Textbook image. What's this we're looking at? Anybody? You guys seen it clearly? What are we looking at? Any takers? What's this big worm-like structure right here?
Is that from ERCP?
That's right. This is an endoscopic retrograde cholangiopancreatogram. This is your upper GI endoscope, going through the esophagus, through the stomach, around the duodenum, and this part is positioned right at the ampulla. So it's endoscopic. Retrograde means they cut the sphincter and then inject contrast up through the distal common bile duct. It's going all the way up. Common bile duct, left hepatic duct, right hepatic duct. This is a more delayed film, so you're looking at intrahepatic ducts. And what do we see right here?
A stone.
I wouldn't call it, that's not what I would say it was.
A
How would
blockage.
you describe it? You describe this as a filling defect.
A filling
So the
defect.
contrast doesn't fill this area, so it shows up dark. It's a filling defect, and it's quite likely a stone, a common bile duct stone. Common bile duct stone. Can you guys, anybody tell me what would have been the indication for this endoscopic retrograde cholangiopancreatogram? Why would this patient have had an ERCP? Dilation plus elevated liver function test plus absolutely. So they would have met those three criteria, which tells us that this patient has common bile duct stones. So we already know. We don't need to do any other test to confirm it's there, like an MRCP. Based on those three findings occurring together, we know this patient has common bile duct stones blocking the common bile duct. So we don't need to guess anymore and do any non-invasive tests to find out that it's there. That's what an MRCP will do. What we need to do now is a therapeutic method of removing these stones. So an ERCP in the context of common bile duct stones is for therapeutic purposes only. So the scope is passed, there's a sphincterotomy performed, contrast is injected up to confirm the stone, and then they pass a little tube like a catheter up, pass the stone, blow up a balloon, and then pull like an umbrella, and you pull the stone down. If the stone doesn't move easily, you can actually attach this endoscope to an external lithotripsy machine where it will send shock waves to shatter the stone. So the stone will be crumbling to smaller parts, and then you scoop them out. So an ERCP is indicated as a therapeutic means for removing these common bile duct stones. Once the ERCP is completed, with the stones all being removed, what's the next step? What is the final step in this patient's management? Who can tell me? Once you have done the ERCP and clear the common bile duct stones, what's next to complete this patient's management? What's the final step after ERCP? That's right, an elective laparoscopic cholecystectomy. Wonderful. I'm gonna skip through this. Well, okay. What study is this? Spot diagnosis. Can anybody hazard a guess? What are we looking at?
The large intestines.
Okay. And what are all these little bumps?
Is this Crohn's disease?
Come again. What are all these little?
The hush.
Extensive diverticulosis. So what's this study? It's a contrast study of the large intestine, starting from below. So what would this patient have had done? What study is this? Yeah, it's a Barium enema. It's a Barium enema. It's a Barium enema. Okay. Okay. So we're looking at another Barium enema here. So what does this Barium enema show? What does the arrow point to? Anybody?
I think it's called the upper core deformity.
That's right. There's an upper core deformity. You see the normal lumen and then it narrows down to a little channel. So there's a annular constricting growth within the lumen which has narrowed the channel. So this is almost confirmatory for a adenocarcinoma of the mid to distal transverse colon on a Barium enema. And this is another one with an upper core right beside it. You can't guys ask anything more than that. With another upper core deformity here, and that's what we're looking at. But hang on a second. Okay. Let's skip this one. Well, I really shouldn't skip this one. Can you guys tell me what this diagnosis is? We're alluding to it in a few slides ago, but anybody? You guys getting tired now?
Pneumothorax.
You want me to press on still? Okay. What's the diagnosis?
A pneumothorax with mediastinal shift.
So what's your diagnosis?
Tension pneumothorax.
What's the diagnosis?
A pneumothorax.
Tension pneumothorax.
It's a tension pneumothorax. So what are we looking at here? We're looking at a AP film. The lung is completely collapsed on this side. There are no vascular markings, but what you see is this is your trachea and mainstem bronchus, which has been deviated over to this side, and the left heart border is all the way over here. So this massive pneumothorax with ear leak has been pushed the entire mediastinum across. What's the problem with this tension pneumothorax? Why is it so potentially catastrophic? Can someone tell me why?
Does it have to do with damage of the alveoli?
If that were a problem, I would be lucky. But why is it so potentially catastrophic? So there's an air leak on this side, and the pressure has built up to the point where it's shoving the heart all the way over to the other side. And what's the problem with shoving the heart to the, moving it
There's
all the way?
of blood to the heart, so you have decreased cardiac output.
Why does that happen? Why do you end up with reduced blood to the heart?
Because you have compression of the superior as well as sometimes the inferior vena cava.
That's right, the IVC and SVC. Remember, both of them enter the right heart border almost at 180 degrees from each other. So let's say this is the SVC, this is the IVC. When the heart shifts this way, it kinks them both. So it potentially move from normal cardiac output in 1 minute to 10% or even less within a minute. So cardiac arrest is imminent. Needle decompression followed by a thoracostomy tube. Okay. What's this? Oh, okay. I think this was, I'd taken this off from one of the lectures I was giving. Here's a collapsed wound, ear filled, shift the mediastinum to that side. Anyway. Oh, I've been through that before. Spot diagnosis here. Can anybody tell me what this is? 15-year-old boy.
Gynecomastia.
Okay, so this 15-year-old boy comes to clinic with this. The doc, I'm getting breasts. What do you do for him? 14 years old. What are you gonna tell him? That's right. You're absolutely right. He gets older and puberty kicks in, the testosterone levels will spike and these usually shrink and remove. So it's a wait and see approach, non-operative approach to this patient. I think we started off with this one. I'm gonna skip this one. I'm gonna skip that. Does anyone want to try this one? What are we looking at here? That's right. So this is a laparoscopic port. This is a trocar. This is a sheath. This trocar goes into this sheath together. This is what it looks like. So it's a laparoscopic port. Trocar and sheath together. Trocar and sheath. So with this, when they are placed together, they vary from model to model, but usually have a little arming device at the top, and you move it forward or press the button and you click forward and it is now armed. What do we mean by that? What do we mean by it's now armed? Any ideas? So
The blade is out.
go ahead.
The blade that is attached to it is out, so you can use it for cutting.
Well, you're half right. Because this is a trocar, and the trocar carries a blade beneath. When it's armed, what will happen is when you put the two pieces together and make an incision in skin, and when you place this on the skin, the pressure will now retract just the tip of the trocar to expose the blade, which means that the blade will now cut through the skin and the layers of the abdominal wall. But once you get into the peritoneal cavity and that pressure and that resistance disappears, it just automatically slides forward and recovers the blade. So it's a protective mechanism. So the blade is only exposed going through the abdominal wall, but once you're in, it's resheathed. You understand? So to avoid you having an open blade in the peritoneal cavity where you lacerate bowel and blood vessels. So it's a protective mechanism. So that entire port side carries the trocar, which has a protective mechanism, and the sheath. So once you've gotten in, this part covers the blade, and then you just slide out this part, and this is all that's left. Just a direct communication from outside to inside, a little valve here. And then you can slide your instruments down through the sheath itself. If you notice, it has a little side hole and a little side arm. What do we connect to this little side arm right here? Anybody? What do we connect to this little round opening right here? That's right. There's a tubing which just screws onto here. Here we can pump carbon dioxide in under low pressure into the peritoneal cavity to maintain a pneumoperitoneum, so we have space to operate. How many of these would we use for a routine laparoscopic cholecystectomy? You guys were at the lap chole on Wednesday? How many port sites do we need? 4 port sites. Where were those port sites placed? First one.
Umbilicus.
Umbilicus. Second one.
The epigastrium.
Epigastrium or anywhere up close to the xiphisternum. Third one.
Lower quadrants. Right lower quadrants.
Okay.
In the ileum.
And the fourth?
in the upper right quadrant.
Yeah, upper right quadrant. Okay, so usually use 4 port sides. The ones that are constant are is the umbilical port, and the right upper quadrant port, which is right at where the costal margin meets the marking for the gallbladder, which is where the semilunaris, which is the lateral border of the rectus, meets the costal margin. That one is standard, and the umbilical one is standard, but the other 2 we can play around with. So it's 4 port sides for laparoscopic cholecystectomy. I'm gonna skip these. I'm gonna skip that. I'm gonna skip that. All right, give me a second.